residual draining function and reduction of the inflammation, malnutrition, and the anemia dyslipidemia. ACE inhibitor drugs should not be prescribed in patients who is receiving hemodialysis with synthetic membrane which are capable of generating bradykinin. So we will talk about again about the size of the filter, and we must choose the size of the filter which is suitable to my child. So we have different surface area. From FX pediatric, for example, which is surface area is 0.2. We have surface area, we have filter surface area 0.3 up to 0.9, and we can choose the proper filter by using the surface area of the filter divided by the surface area of the patient, and must be equal 1. The surface area of the filter should never be more than the surface area of the child to avoid hypertension. As for the bloodline, we always use a pediatric size. Okay, maybe some size available for the babies and the infant. It should be of a biocompatible material. And the type of sterilization is always ethylene oxide-free. As for the pump rate, we always use pump rate from 5 to 7 ml per kg per minute. In smaller children, we use the following formula, which is a body weight plus 10 multiplied by 2.5. This is for the regular maintenance of hemodialysis, chronic hemodialysis. But in the first session, it has a special situation. Always in the first session, I have to be gentle in doing the hemodialysis and start with. We choose to start a pump rate which is lower than 5. We may be doing a pump rate which is just about 3 to 5 in order to avoid hypertension in the first session. So the total extracorporeal blood volume should be less than 10% of the patient total blood volume. And system priming may be done with saline, albumin, and sometimes with blood. It should be applied in the first dialysis session for babies and young infants. Also, we use anticoagulants. We may use unfractionated heparin or low molecular weight heparin. There is some indication for using a heparin-free dialysis, like if there is active bleeding, pericarditis, coagulopathy, thrombocytopenia, if there is intracerebral hemorrhage, recent surgery, and recent renal transplant. So we are using this anticoagulant with a special dose for pediatrics, whether unfractionated heparin, which needs a continuous infusion or a bolus at the first of the session, followed by a next dose because it's a little bit shorter acting. So the continuous infusion is for 20 to 30 international kg per hour. It's monitored by the ABPT or activated clotting time, and maybe have some complication like pruritus and thrombocytopenia and hyperlipidemia. So the low molecular weight heparins, we have different types in the market. The most common used is tenzaparin or enoxaparin, like naclixane and Enohip, with a special pediatric dose. For example, tenzaparin is 50 international per kg, and enoxaparin is from 0.5 to 1 milligram per kg. This is monitored by the anti-factor 10 activity and the clinical adjustment of the initial dose according to the visual inspection of the clotting time in the venous air detector and dialyzer is important. Regarding the hemodialysis frequency and duration, we usually use 3 sessions per week, and the length of the session is from 3 to 4 hours to achieve an optimal PT/V of 1.2 to 1.4. We must be sure that the weight loss during the 3 or 4 hour session is not more than 5 to 7% of the dry weight of the patient. We must also always check for the intra-dialytic between the sessions weight gain. So we always instruct the mother and the child, if he is able to communicate with us with certain age, that there must be some restriction on the fluid intake during the duration at home. So the intradialytic weight gain of more than 10% means that there is no compliance and is associated with major side effect during the session. So this is an important question, whether if we are using an intensified hemodialysis is more beneficial or not. So because some centers are using more extended duration of the session with more frequency, like 8 hours more than 3 times per week. So this literature here saying that maybe using an intensification is more important in children, and they can make them having the opportunity to catch up growth like normal children and having a better quality of life. So here, the hemodialysis in children is not just to keep them alive, but to give them some quality of this life. So they came up with a conclusion like intensified hemodialysis modality provide improvement in the quality of life, and biochemical and cardiovascular parameter and likely anemia and nutrition are better in these children receiving the intensified programs, provided that a solution for the problem is found. Intensified dialysis is expected to become a prevalent choice in the treatment for interstitial disease. Of course, it has much more cost to do this program. So to sum up, the requirement for prescription of a chronic hemodialysis for children, we need a pediatric dialysis unit with a complete cleaning approach and a reset machine. We have to check the proper line and to check the proper filter according to the surface area of my child. I have to prescribe the proper pump rate for this child from 5 to 7 ml per kg per minute, and to give him the proper dose of anticoagulant. So the first session of interstitial disease, it's a special category because, as we said before, it has to be more gentle. We have to lower the parameters in every aspect. Maybe I could choose a filter that is lower than the expected one. I maybe prescribe the pump rate to be much more lower. All this is trying to avoid the first complication like the equilibrium syndrome in the first session. Of course, it's a little bit shorter in duration. Maybe the first session is only 1 hour, and I progressively increasing the duration with the following sessions, like 2 hours until throughout 3 or 4 sessions. I can be using the optimum parameters. So checking the dialysis adequacy in children is very important. We have 3 aspects in checking the adequacy: how to calculate the hemodialysis dose, how to check the adequacy by the laboratory indices and the clinical indices. For the hemodialysis dose, we may use the urea reduction rate, as you know, or the KT over P, which I have to be more than 1.2 to be optimal. The laboratory indices, we must check, we be sure that the serum bicarb and the ABG is normal. The serum bicarbonate is from 20 to 26. The potassium is within normal range from 3.5 to 6.5. The serum phosphate within preferably nearer to the 15th centile for age. The serum calcium and adjusted for serum albumin within the age appropriate normal range. Serum albumin corrected calcium with phosphate products must be less than 4.8 millimole. The serum PTH must be less than twice the upper limit of normal for the intact PTH assay. The hemoglobin is a very important issue. We must always be sure that our child is not complaining of anemia, so the hemoglobin must be greater than the lower limit of age-appropriate normal. About the clinical indices to assure that I'm giving the optimum dialysis adequacy for this child, I must always, because we are dealing with the pediatric age group, to assess the nutritional status. So it's very important to assess the nutritional status, because the malnutrition and cachexia is very common in hemodialysis children. It's about 56% they suffer from malnutrition, and 30% have mild to moderate malnutrition. 8% have severe malnutrition. So a lot of causes have been accused for the presence of malnutrition or cachexia in hemodialysis, like the anorexia, volume overload, endocrine disorder associated with the end-stage disease, persistent acidosis, untreated anemia, the associated oxidative stress, and the inflammatory cytokines, the uremic toxins. So all these factors may have cooperated in increasing the CRP, decreasing the albumin, decreasing the beta centiles, making growth failure and resistant growth hormone, cardiovascular complication, which lead all to increasing the mortality and increasing the hospitalization, and decreasing, of course, the quality of life. As for management of the malnutrition in hemodialysis, so we have there is certain criteria for initiating the intradialytic parenteral nutrition. Okay, like if there is 3 months pre-dialysis with hypoalbuminemia, or 3 months pre-dialysis with serum creatinine which is elevated, the weight loss is more than 10% of the ideal body weight, presumed moderate or severe malnutrition, the bad dietetic history. So what about the recommendation criteria for initiating or discontinuation of the parenteral nutrition therapy? So as we know that the parenteral nutrition should always contain certain concentration and amount of amino acids and lipids and dextrose. Okay, this formula provides between 50 to 90 grams of protein per infusion. Patient treated with parenteral nutrition may develop hypophosphatemia or hypomagnesemia, hypokalemia, and they should experience refeeding syndrome. So this systematic review here for the evidence of the use of the intradialytic parenteral nutrition in malnourished hemodialysis, and they came up with a conclusion that the evidence to use this modality is very weak because of the limited number of children in this study. For the clinical indices also, we have to check always for the growth and development of our children. So there is always a regular monitoring of the growth, if they are catching growth, if they are below the centiles in both weight and height. So also the growth failure in chronic renal failure and end-stage renal disease who are on hemodialysis, the incidence is large as well, because of multiple factors like endocrinological disturbance, presence of malnutrition, metabolic acidosis, renal osteodystrophy, and also the age at the onset of renal disease affect the growth. So the infants who are developing end-stage renal disease have a more severe disastrous effect on their growth, just unlike the child who is reaching the adolescent and can optimize his growth rate. So the treatment of growth failure in end-stage renal disease, there is a question about the possibility of using growth hormone therapy. A lot of investigation must be done before using the growth hormone, and all the correctable factors must be treated. And a lot of literature also recommended to use the growth hormone that say that maybe there is increase in the growth, like 3 centimeters per year velocity, which is a good standard, but we have a lot of difficulties in our country using this type of therapy in end-stage renal disease because of the cost. The high cost is a very expensive drug, and because of the insurance system who doesn't approve to use a growth hormone when this comorbidities like end-stage renal disease. To sum up, so hemodialysis for children should take place in specialized pediatric center able to provide multidisciplinary support, and the transfer process for adolescents must be in place agreed by the referring and receiving unit. Dialyzers and lines must be available in different sizes. Synthetic and modified cellulose reflux membrane are recommended, while the high flux membrane should be considered especially in the chronic long-term dialysis. A fistula should be considered in children on long-term dialysis. Psychological preparation is necessary before the fistula is done, and paired during needling should be prevented. Vascular access surgery should be undertaken by a trained and skillful staff. A KT over V of 1.2 should be minimum for the children and should be checked monthly. Measurement of nutritional status and growth and development should be regularly used as a part of the assessment of dialysis adequacy, and try would need regular reassessment in a growing child. Thank you.
Thank you, Dr. Rashad, for your simplified overview of hemodialysis in children. You reported how crucial is the difference between hemodialysis in pediatrics and adults, including the creation of vascular access, dialysis machines, bloodlines, dialyzers, anticoagulation. Not only this, you show that we need a multidisciplinary team approach in managing this pediatric group, including care for nutrition and even psychological support, and social workers, and even the renal transplant nephrologist should give his effort to prepare some patients for renal transplantation. Now we are ready for questions.
Merci, professeur, de votre présentation. Moi, ma question repose sur l'accès vasculaire, c'est-à-dire sur la fistule. Pour éviter, selon votre expérience, pour éviter les complications ultérieures qui sont dues à la fistule, à quel âge limite on peut faire cette fistule? C'est ce est recommandé d'être fait chez l'enfant. L'âge limite minimum. Merci.
So I think it's not about the age, it's maybe about the weight of the child. Maybe about the weight of the child, because we as you know, the chronic disease can affect the weight in spite of the age. So we also use the weight, and also the vascular surgeon have a very precise comment about the diameters of the vein and the size of the vein can withstand the process of the fistula operation or not. So usually in some centers, including us, we don't use fistula below 10 kilos. And in our experience, when in infants, where they have always tendency for hypotension, even if the surgeon tried to do a fistula, it will fail because of the persistent hypotension, the maybe increased incidence of clotting and thrombosis. So the operation will have a very bad prognosis. Okay, so in our center or experience, we are using the fistula in a normotensive patient, especially when he has a tendency to be hypertensive, like more than the age of 5.
I think the same challenge here in the center when we are preparing child for transplantation. We have our solid criteria, 5 years, 15 kilogram, and the surgeon should inspect the abdomen because we don't have kidney in a small child. So always renal replacement therapy for children are very difficult and challenging.
Thank you so much for your elegant presentation. It's really just, I don't know what to say, just as provide anatomy. Where we have limited nephrologists, you have adult dialysis really. Yeah, case with young guy, maybe he's coming in for dialysis, it's really anatomy. I'm really happy with this thing because really it is something that's keep all the things and be worried about. My simple question is that we show the surface area of the dialyzer with the surface area of the child. You say it's supposed to be around 1?
Yes.
So and you said we should avoid surface area of the dialysis area to be more than that of. This means like really as it is happening, we need a lot of variety of surfaces in that sense. We don't have that ratio at all. And patient are paying. So almost like 1 hour per sessions is almost like the parent will not even accept it. So we are battling with this. If assuming have that kind of patient, how do you think I can better it out? Parents, they mobilize the money, maybe like KDB, maybe you are doing for them. They pay the money, then you can say 1 hour and then go up. So what do you suggest on that kind of situation?
The first part of the question, the surface area of the child and the surface area of the film.
We said that we have the ratio divided to be equal one. Okay, we don't want to put a large filter like we are using in adults in a small child and make it a surface from high protection and skin complication. So I will choose the appropriate size of the filter according to the every size of the filter have a rated surface area of this filter and they must go with the size with the surface area of the child. So you should calculate the surface area of your child by many equations. Okay. So you have the surface area of the child and show the proper surface area matching which is written on the film.
The first initiation, first session, they said you can do 1 hour. For us, because the parents pay for
The initiation of dialysis in child.
Yes.
For starting sessions is 1 hour, 2 hours, half an
We
hour.
say that I didn't talk in much details about the first session because of the time element, but the first session in children must have a unique character, okay? Because we want to avoid complications and we want to avoid what's called the equilibrium syndrome. I'm sure that you heard about it from the adult experience. So we have to limit and downgrade all the parameters. I'm not quite want to have an efficient first dialysis. It's not my aim at all. It's not my target. I don't want the phenocreatinine drop from 10 to 2 to be an efficient dialysis. It's contraindicated. I'm putting my child into too much risk. So I want to downgrade all the parameters. I want the duration to be very short, just about 1 hour, and I can upgrade the duration throughout the next session, slowly, very slowly. The pump rate also is very small. We can start by 3. Although the optimum is from 5 to 8, I also start by 3. I may choose a filter which just 1 number below the optimum for his child, so all the parameters are low, and steady, and gentle precision.
So it is the same approach in others. And the difference is the difference in efficiency of the analyzer. So principle is the same.
Thank you very much. I wanted to ask about peritoneal dialysis. Where I come from, hemodialysis is not so easy because of financial reasons, and our nephrologists choose to do peritoneal dialysis for majority of patients, and some patients who have hemodialysis. I wanted to ask what is the outcome of peritoneal dialysis when compared to hemodialysis in children? Is it a good dialysis?
Okay, this is a very good question because I think that it's a center-based experience. So around the world, there are a lot of centers who are doing the peritoneal dialysis with so much success rate. Okay, others are doing the hemodialysis with the best achievements. Okay, so it's about what you are doing best, then you are doing. So it's not about that this is good and this is bad. It's not about this. Every modality has a specific advantage and disadvantage. So in our center, we are doing the hemodialysis best. So even we could do dialysis for children or infants who are just below 10 kilos. We perform dialysis for 5 kilograms and 7 kilograms. So the indication for peritoneal dialysis in our center is very limited, excluded for the patients who I can't do hemodialysis, like they have a severe vascular, I can't have a vascular access for them, or severe heart failure or a septic shock. Okay, So we don't have the recent automated machines for the peritoneal dialysis to do a chronic peritoneal dialysis. So the success rate of peritoneal dialysis using the traditional methods in our centers or in our experience is very limited success, because we always experience with a lot of handling and poor septic techniques, the high infection rate, failure rate, and thrombosis and to the peritoneal care. So we don't use peritoneal care except for the urgent cases, for acute courses, in order to be taken and an acute kidney injury for instance, and if the child is an end-stage renal disease, he will have peritoneal dialysis for an acute course till the condition permits the hemodialysis.
My question to you, Dr. Nashwa, do you prefer hemodialysis because of lack of facilities? And what about the epidemiology of PD and HED worldwide?
The question
We
is...
are obliged here to do PD because of lack of facilities in PD. Hemodialysis because of lack of PD. Am I right or wrong?
In our center?
Yeah.
Maybe because
In
we...
Egypt there is no automated PD. Do you know if
So we have a high failure rate in performing the acute aiming to a chronic peritoneal dialysis because of the lack of facilities. So we don't have much experience to tell you.
So sometimes the lack of resources oblige us to do this. But I think PD is preferable for children and infants.
There is no solid guideline saying that I think it's more that the literature reviewed that it's some sort of center experience law. But there is no solid guideline saying that the peritoneal dialysis is higher than the hemodialysis. In children, of course.
Yes.
Je vous remercie aussi. Je remercie à mon tour le professeur. Moi, je m'occupe de la néphrologie chez les adultes. Et il n'y a pas assez de néphropédiatres chez nous, dans notre pays. Donc, pour les cas d'insuffisance rénale chez les enfants, il arrive que nos collègues nous appellent pour des avis. Et pour caractériser l'insuffisance rénale, on a besoin quelquefois de la taille du rein. Et donc, chez les enfants, on ne sait pas comment s'y prendre pour apprécier un rein atrophique ou bien de taille normale.
The evaluation of the size of the kidney by the ultrasonography it has different numbers, okay, according to the age. So everything is interpreted and determined according to the age and according to the centiles. So the radiologist have the centiles and have the age limited a normal range. Okay, then he can decide if this length of the kidney, okay, can go with the normal range for the child according to his age, or it's below the normal. So if it's below the normal, this may have a chronicity index.
And regarding the ultrasound evaluation of kidneys in child, in the case of obstructive neuropathy, we shouldn't lose hope in drainage of the kidney. So in adults, thin atrophic parenchyma means that the kidney will not be salvaged. But in child, even if there is obstruction and thin atrophic parenchyma, we may drain the kidneys because the growth of parenchyma in children is not like adults. So this is some difference between child and adult regarding ultrasound of the kidney. Any other question? At the end of the presentation, I would like to thank and appreciate your coming, Dr. Nashwa. It was a very wonderful presentation, excellent presentation. Thank you very much.
Thank you.